This conference will now be recorded.
Hello everyone, good evening and welcome to this orientation session of MRCOG Help Group. So today I'm going to talk about Part 1, MRCOG Part 1 exam. Myself, I'm Dr. Bhavna Khera and me and my partner Dr. Jhuma Biswas. We two are we founded this MRCOG Help around 3.5 years back. Good evening, very good evening, Dr. Manikam Jairam. So we founded this MRCOG Help 3.5 years back. The main purpose of founding this MRCOG Help was that when we prepared for the sessions, we find that there was lot many confusions and difficulties. The clear sources of information were not very clear, so you have to dig out multiple sources, and then things become complicated because by the time we come and take this exam, we are actually into either the jobs or have already begun our family life. So too many complications and with time limitations, I would rather say. With so many responsibilities, we have time limitations. We cannot study for like we studied in our MBBS or PG days when we just used to sit and study for multiple hours. So with increasing responsibilities, we need some guidance so that we can directly shoot our arrow at a target, right? So what happens, why people think that MRCOG is tough? That's only because the direction, the preparation, how you have to do for this exam is different from what we do for our preparatory exams. So that makes this exam tough. But otherwise, no, it's not at all tough. If you are thorough with the knowledge and you know that what to study, I would rather this say smart study. If you study smart, it becomes very easy. And let me tell you, I did all the parts in first attempt and one after other, so that in few months it was over. So no, you don't have to take multiple years or multiple breaks. Nothing is required. So that is why if I have seen, not me, there are many other candidates also who have done everything in first attempt, and just 1 year, 13 months or 16 months, they just finished. That is like how quick you can get next exam. So that just makes a difference. And one after another, one, second, and third, and you are done with it. And it's really a simple thing if you know how to do it, if you get a proper guidance for it. That's it, nothing more. Because already I think in India we are so much like we are reading too much. So we have already gone through most of the things. Just we have to uh, actually do our mind, train our mind to go through the RCOG way. That's it. So let me talk about how this exam helps, how the format of this exam is, and then I will in the end take a small anatomy session to demonstrate how we help you in preparing for the exam. So this is actually, my session is particularly based for all those who are beginning to study for the part 1, or who are thinking of part 1 but yet not they have accumulated so much of courage to start it. Still they are into the spell that when to start. So this session is going to help all those, and certainly all those students who have already booked with us, they are also here, so they'll get to know how we are going to proceed through the sessions. So this is about me and Juma. We both have already done our MRCOGs. I'm practicing practitioner in Lucknow, a hardcore obstetrician, now entered into the field of cosmetic gynae, and I'm also a course coordinator for fellowship courses of cosmetic gynae in institute which is affiliated to university, German university. Juma is working after MRCOG in the London in UK, so she is already attached to NHS. So whatever we teach, you really get a real time exposure of the things happening in the UK. So that is the basic main advantage of this. So now My agenda today will be what are the MRCOG career prospects, overview of MRCOG, facts and myths regarding the MRCOG, and I'll focus on part 1 syllabus and exam schedule, books recommended by the RCOG and books we recommend, concept of smart study, why and how it helps you by choosing the right mentor, and then followed by an anatomy session. Understanding MRCOG. So MRCOG, so few of them might be wanting to go to UK. So yes, this is a direct route to UK. You have to do all your 3 parts, 1, 2, 3. And then you can give take one English test, that is O8 or IELTS, and apply for the GMC registration. Once you get registered there, you get a license to practice, and then you can apply for your jobs in the UK. Second is there is also another route which is MTI route. Okay, in that case you just have to pass the MRCOG part 1 and then you can apply through the MTI route. So that MTI route, the vacancies whenever there are, they will publish on the sites, and if there are ready consultants who are recommended you, or there are any recommendations, or your CV is so much strong, then they can take you directly through the MTI route also. Route to other countries, like if you don't want to go to UK, how MRCOG is going to help in your practice? Quite often when people are thinking of MRCOG, they call me and their question is why they should go for MRCOG if they are not going to UK. Then the answer is that if you are still looking to go outside India, like you want to practice in Middle East, Dubai, or all these countries, they don't take MD as a basic degree. Indian degree, they don't actually take it much, so they don't allow you to practice independently. But once you are MRCOG, yes, you gain an edge over that, and you can do a practice there. So that way it helps, it gives you a certain edge. And if you are applying for the corporates in India, certainly they also give you take MRCOG as an extra degree, extra accomplishment, and they know their importance and they really see you with the respect and give you edge over the others. Now, if you are not going to get attached anywhere and you are into your own private practice, running your own nursing home or something, then how it is going to help? So in that case, MRCOG is going to help because it is a curriculum which is much beyond obstetrics and gynecology. First and foremost thing is that we still don't have very clear-cut guidelines in our curriculum when we study for our PG days. Okay, so what we get to know is how our professors or how things are practiced in our units, in our hospitals. But here you have very clear-cut guidelines, so your knowledge is totally polished. So you become very clear. You know what is evidence-based. Now, this all is much beyond, I said it is much beyond obstetrics and gynecology. So when I say this is much beyond obstetrics and gynecology, what does I mean? I mean that this makes you an excellent mentor. This makes you an excellent researcher. This develops a good communication skills, many soft skills which are known as non-technical skills, because in India, and I don't know about Bangladesh, Pakistan and all these countries, but I don't think we pay very much this importance to non-technical skills. We are predominantly concerned on gaining the technical skills. So once you are through this whole curriculum of 3 parts, by the end you finish, I would say your personality is completely transformed. You feel much more confident, much more patient, and much more developed to deal with your patients. And very soon, by the time you develop all these changes, and within 6 months or 1 year, you will get a positive response from your patients, because that good thing which comes into you, that that gets reflected in your outdoor practice. Okay, how to deal with patients, how to talk about the breaking bad news, how to deal with the angry patient, multiple things. There are small things which are going to bring changes into you. So even if you are not planning to go outside, still MRCOG is going to help you in your practice. So this is why, the answer of why MRCOG, right? If anybody has any query related to this particular point, you are welcome to ask. I'm going to make it a totally interactive session. I don't believe in lectures. My teaching is always totally interactive. So if anyone wants any query at this particular point, you are welcome to ask. Okay, so this is the MRCOG exam format. We all know that there are three parts: part 1, part 2, and part 3. Okay, so part 1 and part 2 is a written exam. So part 1 and part 2 we have twice a year, usually July and January. So in these two parts, we have the written. Basically, now it is totally online because of COVID and all situations. So online exam is being going on. So computer-based exam is there. You have to go to a center where you will be provided with your technological device, which is laptop, computer, whatever is there, and there you have to attempt the exam. So part 1 exam is totally the single best answers. We have a lead with 4 or 5 options, and you have to choose one option which is correct. Okay, so single best answer. What does single best answer means? There may be 2 or 3 options which are, or which you think may be the correct one, but then what it says, what the question says, single best answer. So you have to choose one best answer out of it. So this is how your part 1 questions are. There are 2 papers, part 1 and paper 1 and paper 2. Both have 100 questions, right? So 2.5 hours are given to you for those 100 questions, and you have to do that paper. And results will be published around 4 to 6 weeks after your exam, and you will get the result in your email. And the cutoff marks are not fixed. They are decided by how the candidates have performed. Okay, and questions also do not carry equal marks. They have different marks. The easy questions will have a low marks, and the tough questions will have a higher marks. So if you have attempted one tough question, you gain more marks as compared to 2 or 3 easy marks. So it is different, and there is no negative marking. So it is always recommended that you attempt all questions. Okay, so this is about the part 1 papers. Part 2, we do have paper 1 and paper 2. One is predominantly obstetrics and second is predominantly gynae. Why I said predominantly? Because there is no clear-cut division between obs and gynae. There is quite a lot of overlap in both the papers. You have 2 types of questions there. One is the same, which we have done in the part 1. That is the single best answers, and the other one is extended matching questions, right? The extended matching questions are the one which are really the bone of contention here, because you really need to study hard for that. You need to have a very thorough knowledge, very less chance that you will get an option correct just by predicting the answer. Okay, so that is the main point which is important in part 2. What are extended matching questions? You have around 15-20 options. And instead of 5 options, you have 15-20 options. And then there are 3 voices not clear. I think it's okay from my side. Is everybody facing this problem of voice, or my voice is clear for all of you? Can somebody text or unmute and speak?
Ma'am, part 2, your voice was not clear, ma'am.
No, I just, yes, okay.
Ma'am, for
Okay,
part
so
2, your
I'll
voice is
repeat.
not clear.
Okay, so maybe it was some net issue at your end, but I'll repeat part 2, right? So part 2 is again a written exam with I said there are paper 1 and paper 2, obstetrics and gynecology predominantly. One paper of obstetrics and second is predominantly paper of gynecology. But still there is an overlap. You cannot demarcate that this is obstetric paper and this is gynecology paper. There is quite an overlap. We have two type of questions, single based answers and EMQs. Single based answers are same as I talked in the part 1 exam. EMQs are the one which are a bit different, and they are basically a bit, why they are considered tough, because you cannot predict the answer in that. You need to have a thorough knowledge for it. So there are around 15-20 options, and then there are 2-3 scenarios below for these 20 options, and these scenarios are more or less related to a single thing. Like if they say that patient came into labor at this particular 2 centimeter dilatation, this is the CTG, this is this, what you have to do. Then the second question will be after 4 hours, this happened. Now what you will do? Then after that, in full dilatation, this happened. So these are related scenarios. Okay, it's like you are dealing with one same thing. And then you have to choose the answers for the EMQs as per your guidelines. Okay, as per the guidelines. So there are multiple guidelines, green top guidelines, NICE guidelines, which have to be studied for part 2. In part 1 also, we need some of the guidelines, but not in that much detail. So some summaries are important for part 1 also, which we cover. When we teach you, we cover all those parts which are required for the part 1. I'm just coming to the resources, how we have to do. So I'm just covering the format part. Part 3 is the OSCE, which is the oral structured exam. So there are 14 stations, and these are like vivas. In some stations you have patient in front of you. It is like you are consulting a patient in your chamber, and your examiner is just looking at you and he is marking you. Sometimes you are talking to examiner directly, and it is like a viva station. Sometimes you are teaching your junior. So this type of stations are there. 14 stations in a row you have to do. You usually have exam May and November. Sometimes they may give you an extra slot, like this time there is exam in February also, which is extra. But usually it is fixed in May and November. Now, what are the common myths and facts? It is necessary to go to London for experience? No. You can do it from your home country. All the preparation can be done from sitting from here, and now with the advantage of this online teaching, it has become really easy. You can do it from the convenience of your home, and now the exam is also online, so everything is being done from your home place or hometown or some nearby city where you book the center. Part 1 and part 2 you have to go to center, but part 3 is from your home. So therefore it is very convenient. If at all this online exams ends and then on-site exam begins, when the COVID settles down, then the centers of part 1, part 2 and part 3, all of these are in India. So you don't have to go outside. It's your choice. You want to go and appear in London, that's fine. But otherwise it is not required. So you can do it from your home country, sitting at home. So that is why this is a very good qualification to add on, because you don't have to leave your family, you don't have to leave your work, you don't have to go anywhere. You just have to study, make a schedule, and just have to study for some time, and you can add this important gold standard qualification in with you. Myths and facts, it is very tough, takes lot of attempts to pass. You might have listened from quite people that, oh my God, it takes years and it is really difficult, but I would say no. You need to understand the pattern and focus your efforts accordingly and be strategic. A good strategy will help you complete this exam and go through in a single attempt as soon as you get an option of next attempt. Okay, so maybe just 1 year, maybe just 1.5 years, that is enough. You can do one after another, 3 parts, and you are okay with it. Just you have to be very well planned and strategic. You cannot work with exam preparation, no. It is not an exam for which you will just sit for 15 days and study, no. As you keep on study 1 or 2 hours daily and you are consistently working on it, things get piled up in your mind and you have the answers which you have to choose from the given answers. You don't have to write essay. So basically, as the rules get fixed or as the information gets fixed into your mind with your practice, there is no importance of reading, taking a leave and sitting for 15 days and studying. Okay, so whatever you are consistently practicing, that gets settled in your mind and that helps you crack the exam. So targeted study and consistent efforts. Most important is that when somebody guides you, when we teach, like we are teaching, we highlight those points, that this is the favorite point of art surgery. You have to take care of this point. Remember this point very nicely. Then you go and practice question. The same point will come into the question. So it's like maths. You get formulas fixed in your mind, then you can apply into various questions. So targeted study and consistent efforts. So now I come to the syllabus. As I said, we have paper 1 and paper 2. Paper 1, the subjects are anatomy, biochemistry, embryology, endocrinology, epidemiology, statistics, genetics, and physiology. Paper 2 is biophysics, clinical management, data interpretation, immunology, microbiology, pathology, and pharmacology. So very clearly they are divided. Now the percentage of questions is also divided. So according to that only we give time to that particular subject. Like in paper 1, anatomy is a very important subject, 15-20 questions. And it is very scoring also because facts are fixed in anatomy. If a nerve is a branch of that particular nerve, it is going to be a branch. It's always going to stay there. So once you have that knowledge, it is fixed. You just have to apply that knowledge. Insertion, origin of muscle will always remain fixed. It's not going to change. So whatever question they change, doesn't matter. Information is fixed. So if you know the proper information, you can score easily on these 15-20 questions. Coming to biochemistry, small subject, just 4-5 questions, often repeated questions. So you just read it for 1 or 2 days and you can score on these questions very easily. Embryology, again, known facts, just you have to apply. Endocrinology and physiology. These are 2 subjects, again, very, very important for the exam, 10-15 questions and 10-15 from physiology. So overall, combining both, there can be around 30 questions. And this is an important aspect. And here you have to understand how the processes are in the body. Like your renin-angiotensin system, like 2-cell theory in the ovary where that FSH LH transition that all occurs. So these things are important parts. Complete menstrual cycle physiology, reproductive system physiology. So these are important points for exam questions. Epidemiology statistics. We haven't read in RPGs or MBBS curriculum, so we are very afraid of this subject. But let me tell you, there are only few things which you need to know. And once you know them, this becomes the most scoring subject because this is maths. If you have done your answer right, it's right. So around 20 questions, you can easily score. Once you are okay with the formulas, once you have learned that, you have practiced a bit, you can easily score marks on it. So anatomy, epidemiology, genetics, again, a good subject to score. Pedigree analysis, if you once know how to proceed through the pedigree, you will score on any pedigree. So you just have to learn the basics and then you can apply as you do in your maths. So that is why this becomes very easy to score in these subjects. As I come to paper 2, now there are biophysics, clinical management, data interpretation, immunology, microbiology, pathology, and pharmacology. Now, the pathology, clinical management, and data interpretation go hand in hand. Why? Like I'm talking of pathology, acute fatty liver of pregnancies. Okay, so what are the pathological changes occurring, or what is the pathogenesis behind this? That is a part of pathology. Okay, now once the acute fatty liver is developed, then what are the things which are going to happen? What are the changes which are going to happen? Like if there is going to be increased liver enzymes, hypoglycemia is going to occur, hyperuricemia is going to occur. So these things, when they are occurring, that is a part of data interpretation. The investigations are given and clinical scenario is there. You have to see what is the diagnosis. So these investigations will form the part of data interpretation. Now, how you manage this patient according to RCOG guidelines becomes your clinical management part. Okay, so these three subjects are like one after another: pathology, pathogenesis, the investigation part by the data interpretation, and the management part will be by the clinical management. So for clinical management, you need the knowledge of RCOG guidelines. Similarly, for data interpretation, also you need the knowledge of RCOG guidelines. So we provide you with the summaries which you require, the enough part which is required for part 1. So that is why it helps here. Microbiology, pharmacology, very fixed questions, fixed content. Once you know what is important, what is not, you can easily go through these subjects. So this is the way how the subjects are covered. This is the pie chart which is showing you. So you can see this anatomy bigger block. Then you see this endocrinology and your epidemiology block, which is also bigger one, and these smaller blocks. Now in paper 2, this pathology, clinical management and data interpretation, they cover a bigger part. You can see the bigger blocks here: clinical management, data interpretation. This is your biophysics, microbiology. So this biophysics and this immunology, they are very small subjects, just five questions, and that too quite a lot repeated, and you score very well on it. So this is known as a strategic plan. How much time you have to devote for which particular subject, how much in-depth knowledge you need for that particular subject. So this is where our role is. When we highlight you that how you have to prepare for it, what are the things you have to take into account. So your study becomes, you transform from hard work to smart work. And so it helps in scoring marks. Difficult modules which can bring you down. So in paper 1, people find statistics difficult, but I won't say so. As you have gone through the formulas, you are very well, you can score in it. Endocrinology, this is a bit confusing because you have many syndromes. This hormone is increasing, hyper, this is going down, hypo, many different things are there. So this needs a basic understanding of all these cycles. Genetics, again, if you are not good with pedigree, then you may lose marks in the genetics. But if you are thorough with these, then there is no issue. See, out of 100 questions, around 60 questions are very easy questions. Okay. Now from 60 to around 80 questions are slightly above average questions, which are based on the common points but slightly twisted. So if you can just apply your knowledge with a bit of twist, you can be in a that 60 to 80%. And when you are in that percentage, you are most liable to pass the exam. Okay, because cutoff is somewhere around 65. So once you have, I tell my students that you always target from 75%. So you are on a very safe side. Okay, so with this enough study, you are much beyond 75%. Now regarding the remaining 15-20 questions, which are very typical. So you can, you may know these questions or you may not. Sometimes you are able to solve these questions by a bit of idea in your mind about that particular thing which you have studied somewhere remotely. So you can apply your knowledge to that. But still, if you leave those 20 questions, still you are okay with your 80 questions, which is much beyond your pass percentage, and you are able to pass the exam very perfectly. So our main concentration is to bring that particular 80 to 85% of the content to you, so that you can pass it very, very easily. So this is how we have to deal with the syllabus. Any questions till now? Any queries from this part which I have covered? You can write in chat box, or you can unmute and speak if you have any queries. Right? Is everything fine? I'm clear? Okay. So now this is the important dates for all those who are applying for the July exam. Expression of interest deadline is 9th March. Okay. So remember, you have sent your eligibility application already, and fill this expression of interest form. Where you will find it? Go on to the RCOG homepage. Okay. If you have not already created your account, please create your account. Okay. And this account is free of cost, and you just have to put your information there. So those things like your name, your MBBS degree, from where you have done your basic degree, that all you have to do. And then send your eligibility application and fill expression of interest form. These both forms are available on the page MRCOG part 1. Okay. So once you have created your account, log into your account and write MRCOG part 1 exam in the search, and open up that page and fill these forms. Now, books recommended by the RCOG. There are various books: Tim Shart, Clinical Gynecology, Pharmacology, Essential Genetics, Medical Genetics, Genomes, Harper, so much books, okay? And I tell you, when we studied, I really bought 2 or 3 of these thick books, but then I realized that was not to be studied. We just recommend these 2 books. This Oxford book, this is like the Bible of your MRCOG part 1, and this is the book just going to help you best in your course. Okay, so I just recommend reading this book. If you are joining us, our PDFs are sufficient enough along with this book. Just keep this book as your reference behind. But if you are studying on your own, use this book as a basic book, and then use this revision guide as a reference to your textbook, because sometimes you will need explanation, because this Oxford book is predominantly in points. So sometimes you are not able to get the explanation because of these points. For explanations, you can look into the essential revision guide. So your basic book is going to be Oxford, and your reference book, you can take it as revision guide, and rest of the books are not required to read. In your question solving, Andrews and Catherine, these are the 2 main books which you are going to use. Rest all are question banks. Okay, so question banks from strategy, question banks from past MRCOG, so multiple there. We keep on sharing questions in our groups, and you keep on practicing all the question banks when we go through. Now, how to study? What is the good way to study and prepare for these exams? So basically, there should be consistent efforts. As I said, you cannot remember everything if you study in the last 1 week or 10 days. So you have to put in consistent efforts, like small efforts, putting daily or alternate day, or you have to work consistently. Focused and targeted. Don't go haywire. I should read these also, I should read this also, because see, the same anatomy you covered in 1.5 years, and now you are going to cover in 1 week. So you have to be focused. You have to know what RCOG is going to ask. Okay, so focused and targeted study. What is being told to you, that this is the point where you have to focus. Do keep these things in mind. Revise again and again. Instead of going and looking for more and more sources, what you are reading, keep on revising it again and again. Okay, That strengthens the points which are required. So revise again and again those focused targeted points. Solve as many questions possible simultaneously. Why? This fixes the information in your mind. Once you do some question wrong, you will never forget the right answer in exam. So keep on practicing. We give you the formulas. You go and apply these formulas on your questions. Okay. The more you apply to the formulas, the more thorough you are going to become with those points. So solve as many questions possible simultaneously. Smart study. Don't go haywire. I should read this also. I should read that also. Why not I cover this? Why not I cover this? No. This way you will keep on reading and reading. But your main target here is not just to gain knowledge. Your main target is to pass the exam. So you have to be very, very focused. 2 ways to study. You can sit home, study. You have books. You can do a solo study or you can do a group study. It's absolutely your choice. But with my experience, I tell you, group study helps a lot in passing this exam. Because if you discuss questions in the group, you discuss important points. Sometimes you are telling some point, some other students are telling some other points. So you, in a short time, you remember more information. Okay. Nobody has a time to sit for hours and read. Okay. So once you converse with the other students in the group, so sometimes you remember some points and the other one brings in some other important points. So you, in a small time, you will recollect important information. And this way you keep on revising those points also. So that fixes your information. Because the point is that it is not only that you have to learn, you have to revise also. And you have to fix that information in your mind so that when you go to exam, it comes. So for that, you require this type of study pattern. Why we help? Choosing the right help over self-study. So self-study is very good enough. You can go. You have the books. You have all the content. There's a lot of content in all the groups. Even in our group, free group, we have all the books in the file section. So you don't have to buy any books. Just go in the file section. You have all the PDFs and the soft copies. Take out these PDFs and start. But if you get a guidance, if you get a focus, if you get a target, what to read, what not to read, it becomes easy and it saves your time. How we help? We choose the important content, summarize it, make it palatable. We let you understand and so that you easily remember. Presents to you an easy way to remember way. Simultaneously make you practice questions. Our sessions are not just lectures, they are interactive. We do question discussion also, so that once you do the questions, your information gets fixed. Answers to fix the information then and there. Discussion of past paper question in sessions as well as separate Telegram group. There is a dedicated Telegram group 24/7 in which regular question discussion is there from the various question banks as well as the past papers. So you keep on revising those. Subject-wise tests to assess your performance. After we finish one subject, like I take anatomy, 7 to 10 days are given for anatomy. Once I finish anatomy, we'll give you a test link which you can do at your own convenience. Okay, so you can go and do it. You will get your marks and you can assess how much prepared you are for that particular subject. If you find any lacuna, you can go back and improve it then and there. Of course, we are always there to help you cover all your lacuna. Final mock before the exam. So similarly, when you are going for the exam, same exam like conditions, you have that complete exam, paper 1, paper 2, everything like that. All recordings available till exam. All the sessions are recorded and you will have your recordings with you. You can listen to these sessions as many number of times as you want. Sometimes if you miss the session, no problem, you can go and listen to the recordings. Why you choose us over other courses? How we differ from other courses? We provide maximum number of live sessions as we believe in providing information in chunks, not in chunks. Small information, you remember it very well. It is not like lecture. We make it interactive by practicing questions and answers. All modules covered, because many courses actually do not cover statistics. So this is an important drawback. And statistics is a very important part. If you think that you can pass the exam without doing statistics, it is very difficult. It is a large part of the exam. So you have to be very well versed with it. All notes are provided. Test question discussion in Telegram group. We are easily accessible. You can always access us. You can always call or text or whatever way you want to contact us. Loyalty benefits on your journey for further parts with us. We carry out part 2 and part 3 courses also. So as you continue, you are with us. Now I'm going to talk a bit about the anatomy, how we teach in our classes, and this is how we present you the important points and make you remember the information. So this important topics which I'm going to talk today. I'm going to talk about the regional anatomy of the thorax, then similarly the surface anatomy of the abdomen, and a few lines about the abdominal muscles and in their attachments, their insertions, then umbilicus and diaphragm. So few small topics I'm going to cover. See, you have to know the basic concept of anatomy, and also you have to know what is the clinical application of this basic concept. Why we are reading this concept? Because just knowing the concept is not important. What is the clinical application is also important. So what I'm going to do is I'm going to tell you the anatomy, and then I'm going to correlate that with the clinical concept also, for which knowing this anatomy is important. So you see, this is the surface anatomy. So T2, at T2 vertebra, there is the suprasternal notch. T4 is the angle of Lewis. So T2, suprasternal notch, and just below this is the sternomandibular joint, and this is basically the T4, which is known as angle of Lewis. Now, what is the importance of this particular plane? It is a site of second costochondral joint. That is the junction marking the second rib, from which you will count the lower spaces down. Also, it is the upper limit of surface marking of heart. You can see this is the picture of heart, and this is the upper border, and this is the surface marking. Fourth intercostal space. So we have to count the intercostal spaces with reference to this. So this is the fourth intercostal space, and this marks the dome of the diaphragm and the uppermost edge of the liver. T9, this is the xiphoid process, and this is the part where the T9, this is at the level of T9 vertebra. So always use the diagrams to remember the anatomic points. Diagrams are the best way to remember anatomy. Otherwise, you will always forget. So on the upper border, this is T2, suprasternal notch. This is T4, which is angle of Lewis, and this is mandibular-sternal joint. And here it is the second costochondral junction. And this is the upper border of the heart. Then we come to the fourth intercostal space, which has the dome of diaphragm and the uppermost edge of the liver. And T9 is the xiphoid process. Now, looking at the ribs 1 to 7, they are true ribs because they articulate with the sternum. False rib 8 to 10, their costal cartilages articulate with the rib above. Floating ribs are 11 and 12, muscle attachments only. So let's go back and see. Till 7, you have these ribs which have their own cartilage. 8, 9, 10 will go and attach to same cartilage. They are false ribs. And then your 11 and 12, they are floating. They just have muscle attachments. They don't get attached to the sternum. Now, costal margin is the medial margin formed by the false ribs. What is the clinical application? When aspirating or inserting a chest drain, the position of the neurovascular bundle should be remembered, and access should be achieved by running the needle or drain over rib rather than under it. Because the neuromuscular bundle, it runs along the lower border of the rib. So whenever you go to the near the lower border, when you have to go in this intercostal space, and you are going near the lower border, you are likely to injure the neurovascular bundle. So whenever you have to insert any drain, drain it try to be near the upper border. So once you are near the upper border, you are less likely to injure the neurovascular bundle. The other important thing is fifth intercostal space in mid-axillary line is normally used. So fifth intercostal space in mid-axillary line is normally used. So mid-axillary line is the one which passes through the axilla. So fifth intercostal space is to be used in the mid-axillary line on the lateral part. But in pregnancy, because of the contents, increase in the abdominal contents or pressure from the abdominal contents, this gets higher up, that dome rises. So instead of fifth intercostal space, you go one space higher for the raised diaphragm. The parietal pleura is innervated segmentally from the intercostal nerves, and therefore when inflamed produces pain, which is referred to complete cutaneous distribution of that nerve. So these nerves which pierce and come out, and they innervate the area over the skin. The same, they are also innervating the parietal pleura. So like if there is any parietal pleura inflammation, like there is pleuritis, okay, so in that case the pain will be referred to upper part of anterior abdominal wall, because the same nerve is carrying the cutaneous branch to the skin. So anterior abdominal pain can arise from pleural irritation mimicking an abdominal event. So it actually leads to this pain, but actually it is from the pleura. So this is how the pain from the pleura can be referred to anterior abdominal wall. So we have these three clinical applications when we talk about the ribs. Fine. Any questions till now? Is it fine? Okay, so we talk about the diaphragm now. This is a muscular tendinous structure which separates the thorax from the abdomen. It arises from the xiphi sternum. So in the center, this is the xiphi sternum. It arises from the xiphi sternum, and it also arises from the lower 6 ribs. You see it is arising here, and their costal cartilages, and median and lateral arcuate ligaments. Median and lateral arcuate ligaments are the thickening of the fascia on the posterior abdominal wall muscles. So quadratus lumborum and psoas major, they are present on posterior abdominal wall. The facial thickening of near their attachment onto the vertebra, there is medial and lateral arcuate ligaments. So posteriorly the diaphragm will come from those arcuate ligaments. Anteriorly it is coming from the ribs and the costal cartilages and from the central xiphi sternum. Posteriorly it is coming from arcuate and the medial and lateral arcuate ligaments. The first 3 lumbar vertebra on right left crus and fuses into a trifoliate central tendon below the pericardium. So it also comes from the 3 lumbar vertebra on right hand side both. So it will form right crus and left crus. So all these will come, and this trifoliate tendon. One is coming from the posterior wall, one is coming from the anterior wall, and one from the lumbar vertebra. So all these 3 will get attached and form the central tendon, which is below the pericardium. Now the blood supply comes from the lower intercostal arteries superiorly and the phrenic arteries branches of aorta inferiorly, right? So superiorly they are coming from the lower intercostal arteries because the ribs, the supply is from the intercostal arteries. So same comes here and supplies, and the other artery which comes is the phrenic artery, which is directly the branch of the aorta. Nerve supply is by the phrenic nerve. The root value is 3, 4, 5. C3, 4, 5. Cervical 3, 4, 5. And it is part of the, it is coming from brachial plexus. So phrenic nerve C3, 4, 5. And sensory supply is by the lower 6 intercostal nerves. So motor supply by the phrenic nerve. Root value you have to remember very nicely. So C3, 4, 5. And sensory is by the lower 6 intercostal nerves. Now structures piercing the diaphragm. This is an important point for exam question. Particularly, we talk of 3 heights, that is T8, T10 and T12. They are the major one, which really are being asked in the exam. So let's see. T8 is basically inferior vena cava when it is coming from abdomen and entering into the thorax. So inferior vena cava and the right phrenic nerve. So they will be in the at the level of the T8. This hiatus is at the level of T8. Another hiatus which is important is T10 at the level of T10. T10 it is esophagus. And along with the esophagus on anterior and posterior walls, there are anterior and posterior vagal trunks. Phrenico-abdominal branch of the left phrenic nerve, esophageal branch of left gastric artery, and esophageal tributaries of left gastric vein. They accompany the esophagus. But mind you, for exam point of view, if you remember 2 things, esophagus and anterior and posterior vagal trunks, that's enough. So esophagus and anterior and posterior vagal trunks is enough to remember. Now aorta, this is aortic hiatus. This is T12 at the level of T12. Aorta, zygous and hemizygous veins, thoracic duct, aortic plexus, and additional lymphatic vessels. So basically aorta and lymphatic vessels. So they are part of this T12. So T8 is for inferior vena cava, T10 is for esophagus, and T12 is for aorta. Minor apertures are there in which there are greater splanchnic nerves, lesser splanchnic nerves, least splanchnic nerves. Sorry. Zygous and hemizygous veins. Then this is foramen of MRCOG, left and right, quite anteriorly, and they are for the internal thoracic artery and veins. Sorry. The internal thoracic artery is predominantly the artery which supplies the structures in thorax. But as the terminal branch of the internal thoracic artery passes these foramen or MRCOG and enter into the abdomen, it gets transformed into the superior epigastric artery, right? So superior epigastric artery is nothing but the terminal branch of internal thoracic artery. Terminal part of internal thoracic artery, as it enters into the abdomen, it becomes the superior epigastric artery. So these is about the apertures of the diaphragm. Fine, any confusion? Any confusion, right? Okay, so we move on to the next topic, that is the anterior abdominal wall. Okay, so these are the basically the structures of the anterior abdominal wall. So as you go from outside into the deep, first is your skin, then this is fatty layer of superficial fascia, which is also known as Camper's fascia. So superficial fascia has 2 layers here. One is the fatty layer and one is the membranous layer. So fatty layer is known as the Camper's fascia and membranous layer is known as the Scarpa's fascia. Below this, there are 3 muscles, one below the other. So outer one is the external oblique, then this is internal oblique, and then this is transversus abdominis. Below this transversus abdominis is again this is the parietal layer of peritoneum, and in between the two, this is the extraperitoneal tissue. Once you go beyond parietal layer of peritoneum, you enter into the abdominal cavity. Now, all these muscles have their own fascia. Okay, so this this posterior part of transversalis abdominis is also covered by the fascia transversalis. So all these muscles have their own fascia. So now we repeat: skin, fatty layer of superficial fascia, which is known as campus fascia. Then this is membranous layer of superficial fascia, which is carpus fascia. Then external oblique, internal oblique, transversus abdominis. Below this, transfascia transversalis. Then there is extraperitoneal fat and parietal layer of peritoneum. Once you go deep, then there is abdominal cavity. There is no deep fascia in the anterior abdominal wall. You see, directly after superficial fascia, the muscles are starting. Now, these are the regions, abdominal regions. So the two lines, one is this mid-axillary line, mid-clavicular line. These vertical lines are mid-clavicular lines. And these two horizontal lines, this is the subcostal plane. See, it is just passing below the lowest part of the rib cage. So this is subcostal. Subcostal just below the costal margin. So this is subcostal. And this passes through the L3 vertebra upper part. So it passes through the upper part of the L3 vertebra. Then this is intertubercular plane, L5 vertebra upper part between the two tubercles. These tubercles are on the iliac crest. So this intertubercular plane, and it passes through the L5 upper part. So these two planes and these two mid-clavicular lines, they divide the abdomen into the 9 parts. So you see on the top, this is the subcostal margin, which is the uppermost boundary, and the lower boundary of the abdomen is this inguinal ligament. Okay, so the superior boundary is by the costal margin and inferior boundary is by the inguinal ligament. Now, what are the 9 these areas? What are their names? Central one is the epigastric. We all know, very commonly we say epigastric vein. This is umbilicus, and below the umbilicus is hypogastric. Now on both sides, this is right hypochondriac, this is left hypochondriac, this is right lumbar, this is left lumbar, this is right iliac fossa or right inguinal region, and this is left iliac fossa or left inguinal region. I'll repeat. Central ones are epigastric, umbilical, and hypogastric. Left side is left hypochondriac. Right side is right hypochondriac. Then there is left lumbar, right lumbar. Then there is left iliac fossa and right iliac fossa. So this is how we have 9 regions. Now, surface anatomy of abdomen is very important. So L1. L1 is the plane which is the transpyloric plane of Addison. So this is one which passes through the L1. So somewhere here it will be. You see, this is the L3, L2, L1. So it will be somewhere here. This L1 plane is very important plane, and this is known as transpyloric plane. Why? Because it passes through the pylorus of stomach. So this plane is actually halfway between the suprasternal notch and pubis. So you see, the suprasternal notch would be somewhere here because this is the episternum. You have to go above that. So here from the suprasternal notch to pubic symphysis, this plane is going to be the central part. So this is going to be the center. L1 is center between the suprasternal notch and the pubic symphysis. So it lies a handbreadth below the xiphoid and is at the level of first lumbar vertebra and 9th costal cartilage. So now this is L3, L2, L1. So this, if you draw a plane at this point, you are cutting the ninth costal joint. So this is the ninth costal cartilage. It marks the termination of the spinal cord. Structures in this plane include are pylorus of the stomach, duodenojejunal flexure, fundus of the gallbladder, renal hyla, and neck of pancreas. So if you take a horizontal section at this particular point, the plane passes through pylorus of stomach, duodenojejunal flexure, fundus of gallbladder, renal hyla, and neck of pancreas. Subcostal plane joins the lowest costal margins on both sides and marks the 10th rib and the L3. So subcostal plane is just below that. L1 will pass from here. L3 is here. So it is below this. So subcostal plane joins the lowest costal margin on both sides and marks the 10th rib and L3. Plane of iliac crest, it marks the bifurcation of abdominal aorta at the level of L4. So plane of iliac crest will be the highest point on the iliac crest. So if you draw the two lines, then it will be L4. You see this is L3. Now you draw a line here. So it will pass through the L4. This is the point where the abdominal aorta will divide. So this plane is important. Plane of iliac crest, it marks the bifurcation of abdominal aorta and it passes at the level of L4. Umbilicus lies at the lower part of the L3, landmark for the third part of duodenum and origin of inferior mesenteric artery. So umbilicus lies at the lower part of L3, landmark for the third part of duodenum and origin of inferior mesenteric artery. Now let's revise. L1 is a plane which passes through anybody who would like to answer can unmute and speak. What is the significance? Which plane passes through L1? Which plane passes through L1? Anybody would like to answer? Yeah.
Pyloric.
Which one? Yes, transpyloric plane. Very good. So transpyloric plane, yes, very correct. It passes through the L1. And do you remember the structures which it cuts? One is pylorus of stomach, right? Because the name is transpyloric. Then duodenojejunal flexure, fundus of gallbladder, renal hyla, and neck of pancreas. Now, which plane passes through L3? Yeah, anybody? Which plane passes through L3? Anybody? It's written in front of you on the screen. You just have to unmute and speak up. Which plane cuts it, L3?
The lowest costal plane.
Yes, subcostal plane. Very good. And what about L4?
Abdominal aorta, bifurcation of abdominal aorta.
Very good, very good. Bifurcation of abdominal aorta and plane of iliac crest. Very nice. See, if you guys keep on talking, it makes palatable for me also, no? Because otherwise you just sit in front of screen and keep on speaking. If you get a response, it becomes interactive and it becomes interesting. So this is how it is. Now McBurney's point. This is the point which lies 2/3 laterally along the line drawn from the umbilicus to superior iliac spine. So you see this is the umbilicus and this is superior iliac spine. So if you draw this line and you make a point which is at the junction of medial 2/3, and this is 1/3. So this is your McBurney's point, and this is the point where they give the incision for the appendix, but in non-pregnant state. But what happens in a pregnancy? In pregnancy, because of the gravid uterus, the appendix also rises, because the gravid uterus pushes the cecum and the whole structure rises up. So as the structure rises up, the appendix goes higher. Okay, so as the appendix goes higher, this position does not hold true for surgeries in the appendicectomy. So how you will choose the point of incision for the pregnancy? So in that case, you have to choose for the point of maximum tenderness. Where the tenderness is, you will follow that. Because at this McBurney's point, you are not going to get the appendix with the gravid uterus. Right? So the point of incision will be the point of maximum tenderness. Now there are langers or cleavage or tension lines of the skin which result from the collagen fiber arrangements, and incisions placed along these heal with minimum scarring. On the anterior abdominal wall, they lie transversely. So if you give your incision in a transverse manner, then it is less prominent. Now these are dermatomes. What are dermatomes? Any particular area of the skin which is supplied by the cutaneous branch of one particular segment. Like this particular area of skin is supplied by T7. This particular area is supplied by T8. This particular area is supplied by T9. So it is important to remember that around the umbilicus, the area is supplied by T10. Okay. Now, what is the significance? The fibers which are carrying the pain from the uterus, they belong to T10. Now, when there are contractions, then the pain is there and that is carried by the T10 segment. So, T10 you will also feel the cutaneous pain at umbilicus. So, even if the contractions are coming in lower parts, you still feel the pain, cutaneous pain at the umbilicus. So, this is T10 part around which you will feel the pain. Whenever any T10 carrying viscera or something is affected, you will get the cutaneous pain here. So this is the significance of knowing dermatomes. Similarly, here you see S2, S3, S4 in the anal region. So if you give the pudendal block, it is S2, 3, 4. So if that block is given, so the cutaneous distribution of this area is blocked. So you can do the suturing in this area. So that is why it is important to know the dermatomes. Now the important dermatomes which are required to be remembered are T10 around the umbilicus, L1 which is in the anterior 1/3 of the vulva and the mons. So this is important, L1, and posterior 2/3 of the vulva and the anal region and part of buttocks, which is supplied by S1, 2, 3. Okay, so at the vulva, anteriorly and posteriorly, anterior 1/3 is L1 and posterior 2/3 is S2, 3, 4. So you see the junction L1 and S2, 3, 4. L1 anteriorly and S2, 3, 4 posteriorly. So knowing the dermatomes is very important. Now talking about the muscles of the abdominal wall. The muscles of the abdominal wall can be thought of as straight, that is anterior and posterior, and flat muscles, that is the lateral muscles. So first talking of straight muscles. Posterior, if you see, this is the posterior abdominal wall. So you see one is the quadratus lumborum and other is the psoas major. Right now, I'm going to talk of quadratus lumborum. Psoas major, I'm not taking it here. We will come to it when we come to the sacral lumbar plexus, because this is a very important muscle in relation to that. So there are multiple nerves in relation to psoas major. Psoas major is a very, very important muscle from exam point of view, because it has lumbar plexus just below, behind it, And the nerves, as it come from the lumbar plexus, they are in relation to the psoas major. Some they come from the medial border of the psoas major, some come from the lateral border, some come anteriorly, and this is an important exam question. So you have to remember that very nicely. So I'll be taking the psoas major when I will be talking about the lumbar plexus. For now, quadratus lumborum, you see this is the quadratus lumborum muscle, this lateral one. So it rises from the medial border of the 12th rib and transverse processes of L1 to L5, iliolumbar ligament and posterior aspect of the iliac crest. So from all this area, it is attached. Nerve supply is by the segmental supply from T12 to L4. So this is about the attachments and the nerve supply of the quadratus lumborum. Now on the anterior abdominal wall, there is rectus abdominis muscle. We look at this diagram. This is the rectus abdominis muscle. This is external oblique muscle. Just behind this, you cut the external oblique, you see the internal oblique. You cut the internal oblique, then you see the transversalis, right? So after this transversalis, this will be the rectus muscle. So rectus abdominis, it is attached from 5th to 7th costal cartilage plus Ziphi sternum in horizontal plane. So from the upper part of the abdomen, that is 5th to 7th costal cartilage and Ziphi sternum, it is going down. And as it goes down, it attaches to the pubic crest. And when it goes and attaches to the pubic crest, the fibers interdigitate across the midline. Nerve supply is by the T7 to T12 segmental supply from the T7 to T12 vertebra. So you see it is rising from here, 5th, 6th costal cartilage and Ziphi sternum, and it is going down and getting attached to the pubic crest. So this is rectus abdominis muscle. Now, pyramidalis is a vestigial muscle which is absent in 20% of population, which lies anterior to the lower fibers of rectus abdominis muscle within the rectus sheath, and it is supplied by the subcostal nerve. So basically, on the lower part of rectus abdominis muscle here, it is the small muscle which lies in the sheath, and this is known as the pyramidalis. Why we are talking of this muscle? It is very much favorite of RCOG because this is the muscle which gives you the indication that you are giving incision in the midline. Okay, so this is just for the reference point here. It is used for the midline incisions, and it is vestigial muscle and absent in almost 20% of the population. You will see a recall question about pyramidalis when you solve the recalls. External oblique that runs downwards, forwards, and medially, like the direction your hands take when in your pockets. So when you put your hands in the pocket, how your hands are? You go downwards, forwards, and medially. So attachments are angles of lower 8 ribs, anterior half of iliac crest, and anterior superior iliac spine. Pubic, and when it goes attached to the pubic tubercle and the pectineal line on the ipsilateral side, that is on the same side. Let's go and see. This is it coming from the ribs and the iliac crest, and then it forms the aponeurosis, which goes and attaches on the pubic crest. Okay, and the lower end actually curves inside to form the inguinal ligament. So pubic tubercle and pectineal line on same side, that will form the lacunar ligament, and when it gets reflected onto the other side, it forms the reflected part of inguinal ligament. The external oblique muscle has free edge, so it is the inferiorly, this edge is folded in the form of inguinal ligament. Now the internal oblique, exactly 90 degree. The angle of fibers is exactly 90 degree to the external oblique. So instead of going downwards, it goes upwards. The fibers goes upwards, forwards, and medially. That is 90 degree to the external oblique. Attachments are anterior 2/3 of the iliac crest and internal border of lateral 2/3 of inguinal ligament. Basically, from the iliac, it comes from the ribs and the costal cartilages, and as it goes down, it attaches on the anterior 2/3 of the iliac crest and also on the into the conjoint tendon. So together they will go and insert here. So transverses, they are the transverse fibers. They run across laterally. You have seen in the diagram, they are absolutely transverse fibers. So they are just transverse fibers which arise from the inner aspect of costal cartilages of lower 6 ribs and anterior 2/3 of the iliac crest and internal border of lateral third of inguinal ligament. That is from the conjoint tendon. What is conjoint tendon? The insertion of, that is the fibers of internal oblique and transverses. They together form this conjoint tendon. They extend from the inguinal ligament attachment to arch medially and insert into the pubic crest. These muscles, you see, this is the transversus abdominis coming, and this is the internal oblique coming. They both come here and they form the conjoint tendon as they arch and they insert into the pubic crest. So this is the pubic crest, they arch and get inserted here. Yes, you will get the recording of this lecture. I'll post it in the group. So both of these, they get attached to this part and they will form the conjoint tendon. So conjoint tendon forms from the fibers of, you have to remember, conjoint tendon is very important. So it is formed by the fibers of internal oblique and the transversus abdominis, and they both get attached from the inguinal ligament. They first get attached to inguinal ligament, then arch over to get attached onto the pubic crest. This is another reflection which is known as the lacunar ligament, also known as the Gimbernat's ligament. Okay, so you see, this is the inguinal ligament which is coming here and getting attached. Now this is the part which extends back onto the pectineal line. So this is known as the lacunar ligament. The one which is reflected onto the other side, we said it is reflected part of inguinal ligament. Already we talked about the reflected part, because the one which attaches here and then some part goes and reflects onto the other side. So this is the reflected part. Now the part which goes onto the pectineal line will become the lacunar ligament, but as it goes further onto the pectineal line, this becomes the pectineal ligament. So the first part which goes backwards and gets attached to pectineal line is the lacunar ligament. As it goes further and runs on the pectineal line, the extension, that is known as the pectineal ligament. So for now, let me repeat the terms. One is the inguinal ligament, which is the lower folded edge of the external oblique muscle. Once it gets attached to pubic crest, some of the fibers get reflected onto the contralateral side. So that becomes the reflected part of inguinal ligament. Now some fibers will go back onto the pectineal line and they become the lacunar ligament. And then as this lacunar ligament fibers move further onto the pectineal line, they become the pectineal ligament. Okay, so this is the how we have to explain these all parts of inguinal ligament. The neurovascular plane lies between the transversalis and the internal oblique muscles, and the segmental lateral cutaneous nerve pierces the internal and external oblique muscles laterally to supply the external oblique muscles. So your neurovascular bundle lies between the internal oblique and the transversalis. So see there are three layers: external oblique, internal oblique, and transversus. So your bundle lies between the internal oblique and the transversus, and then it penetrates out, branches penetrate out, and they will supply the external oblique and the skin. And the anterior ones, they will again come out and supply the rectus abdominis muscle and the skin. Now we come to another important structure, which is rectus sheath. How the sheath of the rectus is formed. We know that all the muscles have their own fascia. So these are the three muscles. This is the horizontal section of the anterior abdominal wall. So basically, this is the anterior, external, internal, and transverse of abdominis. So external oblique muscle, internal oblique muscle, and this is transversus abdominis. So all of these are covered by the fascia. So three layers of fascia are there. First is external oblique fascia, this is internal oblique fascia, and this is the transversus fascia, which is coming posteriorly. Okay, so now what happens is the external oblique fascia remains in front of rectus abdominis throughout. Transversus fascia goes posterior to the rectus abdominis muscle, but the internal oblique fascia splits into two. Half will go anteriorly along with the external oblique fascia, and half will go posteriorly along with the transversus abdominis fascia. So this way, the two fascia on anterior and posterior will form the anterior and posterior layer of rectus sheath, right? So anterior layer of rectus sheath is formed by the external oblique fascia plus anterior part of internal oblique fascia, while the posterior sheath is formed by the fascia transversalis and posterior layer of internal oblique fascia, right? So this way, these are the two layers. Now what happens when you reach a point midway between umbilicus and pubic symphysis? Okay, in that will be the lower abdomen, a point between the umbilicus and the pubic symphysis, that is somewhere in the lower abdomen. When you reach that part, then this internal oblique, both anterior and posterior leaves, they go in front of the rectus sheath, right? There is no posterior layer of the internal oblique in lower part. In lower part, it is just the fascia transversalis which runs here. So all these three layers, external oblique, anterior and posterior leaves of internal oblique, they go in front. You see, previously it was going here and here. Now they are going all here in front. Only the fascia transversalis here. So in lower part, that is after the midway, after the midpoint between the umbilicus and the pubic crest, the rectus sheath, posterior layer of rectus sheath ends. There is no rectus sheath posterior layer. Directly after the rectus muscle, there is fascia transversalis and the peritoneum, right? So now how the question comes. When you give a fan and steel incision, then what layers you encounter? Okay, so what layers you will encounter? You will encounter skin, you will encounter the superficial fascia, that is fatty layer, and the membranous layer. Then there will be anterior rectus sheath. Then you have rectus muscles. As you move your rectus muscles laterally, you directly get the peritoneum. You don't get anything like posterior rectus sheath, right? Why? Because in the lower part that is absent. So this is an important exam question. Very favorite question of RCOG. So you see, this is the aponeurosis of the external oblique, this green layer, and this layer is this orange layer is the anterior leaf of internal oblique, while this orange layer is posterior leaf of internal oblique fascia, and this is the fascia transversalis. So you see here, now in lower layer there is no yellow orange layer here, both orange layer has moved here. So just below this, is midway between umbilicus and symphysis pubis, the posterior layer is deficient. Now when you give the fan and steel incision here, you will not find the posterior sheath. This picture is also showing the neurovascular bundle where it is going. So you remember I told you it goes between the internal oblique fascia and the transversalis fascia. So here your bundle is going, it penetrates and comes superficially to supply the rectus abdominis muscle. Is this point clear? Any confusion in this point? Right, shall we move forward? Okay, so now I'm going to talk of contents of rectus sheath. Now we know that the rectus sheath is there anterior and posteriorly. What are the contents? So one major content is rectus abdominis muscle. Secondly, we have just studied on the lower part of the rectus abdominis, there is pyramidalis muscle here. So that is also inside the sheath. Now this is the superior epigastric artery and vein. You remember I told you when the internal thoracic artery crosses the costal margin and pierces the diaphragm, enters into the abdomen, the terminal part becomes the superior epigastric artery. So superior epigastric artery, this is from the internal thoracic. So anastomoses with the internal inferior epigastric artery. Inferior epigastric artery comes from the lower side and it is a branch of external iliac artery. Okay, so they both come and anastomose here. Inferior epigastric artery is a very important artery from the exam point of view and very much favorite of RCOG. We'll deal this artery separately in complete detail. But for now, just remember this is a branch of external iliac artery and this anastomoses with the superior epigastric artery, which is the terminal part of internal thoracic artery. So both of these anastomose in the rectus sheath. So if you remember, when you do a cesarean section, you split your rectus sheath. Sometimes when you put your finger, hook your finger and you pull them laterally, the bleeding starts from the lower, from the just below the rectus. So you just pick it up and see the vessel bleeding there, and then you have to cauterize that. Okay, so these are branches of inferior epigastric artery. Now the supply is by the lower 6 thoracic nerves and posterior intercostal vessels. So they also lie in the rectus sheath. So contents are rectus abdominis, pyramidalis, superior epigastric, which is coming from the internal thoracic, and the inferior epigastric, which is a branch of external iliac, along with lower 6 thoracic nerves and posterior intercostal vessels. So together they are there in the rectus sheath. Now there are two important lines. One is linea alba. Linea alba is the avascular fibrotendinous raphe, central raphe. There is a central line which is, this is the linea alba. This is the fibrotendinous raphe formed by interlacing fibers of aponeurosis of 3 lateral muscles of anterior abdominal wall. External oblique, internal oblique, and transversus abdominis. It extends straight from the xiphoid process to the pubic symphysis. From the xiphoid process to pubic symphysis. Why this line is important? This is avascular plane. So when you give your midline vertical incision in this plane, you have no blood loss. This is an avascular plane and it lies exactly in the midline. So it extends from xiphoid process to the pubic symphysis. Then there is linea semilunaris, a curved fibrous line at the lateral margin of the rectus sheath. So rectus sheath, we have just seen formation of rectus sheath on the lateral margin. It is open. So that free lateral margin is known as the linea semilunaris. And it extends from the tip of 9th costal cartilage to the pubic tubercle. Now we talk about the anatomical basis of abdominal incisions. So now the midline incision, it is made through the linea alba because it is almost bloodless line along which abdomen can be opened. But the disadvantage is that it leads to postoperative weakness and herniation may occur. Another incision is paramedian incision. It is placed 1 to 1.5 inch lateral and parallel to the midline, and anterior wall of rectus sheath is opened. Rectus muscle is displaced laterally to avoid injury to nerves supplying the rectus abdominis, and then there is posterior wall of the rectus sheath. See, we are not just talking of lower part, we are talking of whole abdomen. So in almost upper 2/3 of the abdomen, posterior sheath is there. So when you open up the anterior sheath, you retract the rectus muscle laterally, then you will find the posterior sheath that you have to cut. Then there will be fascia transversalis and peritoneum. So this you get in a paramedian incision. Rectus abdominis should be retracted always laterally to avoid injury to nerves that pierce the sheath laterally. So always rectus muscle, you actually deflect it laterally. Subcostal incision or the coccus incision. This is used on the right side for the gallbladder surgery and on the left for the exposure of the spleen. The skin incision begins at the midline and extends parallel to and 1 inch below the costal margin. Muscle split or gridiron incision. This is the McBurney's incision. Already we have discussed what is McBurney's point. So transverse incision is in the line crease 1 inch above and forward from the anterior superior iliac spine, or an oblique incision centered at McBurney's point. What is the McBurney's point? You draw a line between umbilicus and the anterior superior iliac spine, the junction of medial 2/3 and lateral 1/3. That is the McBurney's point, where you give an incision for the appendicectomy. The aponeurosis of oblique is incised obliquely downwards and medially, that is in the line of fibers, and then internal oblique and transversalis are split so that you don't cut any muscle. All the muscles are just retracted along their lines. So once you close the incision, the muscles will again snap together. So there will be undamaged anterior abdominal wall. Now the two important incisions for the cesarean sections are, one is Spannen's tail incision, to which we are very much accustomed to, and this is jaw con incision. In UK, they prefer the jaw con incision. So Spannen's tail incision is a curved incision approximately 10 to 15 centimeter long, and this is 2 centimeter below the pubic symphysis. So pubic symphysis is somewhere here. This is just 2 centimeter above the pubic symphysis, not below, because pubic symphysis is lower down, so just 2 centimeter above that. Now skin and rectus sheath are open transversely using sharp dissection. Remember, you will not have posterior layer of rectus sheath here. Rectus muscles are not cut and the fascia is dissected along the rectus muscles. Muscles are not cut, we just retract them. In jaw con incision, this is a straight transverse incision through the skin, 3 centimeter below the level of anterior superior iliac spine. So if you draw a line here, it is anterior superior iliac spine, 3 centimeter below this. This is a jaw con incision. So it is higher than the Spannen's tail incision. In this case, subcutaneous tissues and fascias are open in the midline and extended laterally with a blunt finger direction. Blunt dissection is used to separate the rectus muscles vertically and then open the peritoneum. In UK, they prefer this type of this incision because here there is all the blunt dissection is there. You are not cutting anything. So they say that the post-operative morbidity is less in jaw concision because no cutting is done. It is basically you are retracting things. So in jaw con, it is preferred over the Spannen's tail in UK because of lower incidence of post-operative febrile morbidity. Less fever and less pain is there. Now the last topic which I'm going to take today is about the umbilicus. So umbilicus is a depressed scar in midline of anterior abdominal wall, normally between the xiphoid process and pubic symphysis. It is somewhere centrally located. It is normally between the xiphoid process and the pubic symphysis, or between L3 and L4 vertebra. It represents the site of attachment of fetal end of umbilical cord, and it is innervated by T10 spinal segment. It acts as a watershed line between the lymph and the venous flow because there are two different areas. Above supraumbilical, lymph and venous flow is different. Below the umbilicus, the infraumbilical region, the lymph and venous flow is different. And umbilicus is also one of the sites of portocaval anastomosis. That is the anastomosis between the inferior vena cava and the portal venous system. Fibrous bands are there which get attached to the umbilicus. So you see three folds here. The three folds you see are the important exam questions. So median umbilical fold, medial umbilical fold, and lateral umbilical ligament. So the median umbilical ligament, this is the one which goes from the bladder. This is the bladder, the fold which goes from the bladder to the umbilicus. So this is the median, and this is remnant of allantois, and this is urachus. Okay, so this is median. This is in the center. Then there is medial umbilical ligament, which is remnant of umbilical arteries. So medial umbilical ligament is the remnant of umbilical arteries, while the lateral one is the fold which is raised by the inferior epigastric artery. So the median is the urachus, medial is the umbilical artery, and the lateral ligament is the inferior epigastric artery. The one which is coming from above, that is the ligamentum teres. This is between the umbilicus and the liver. This is from the falciform ligament. So, falciform ligament by which the liver is attached to the diaphragm. So this is the continuation of that. This is ligamentum teres. So these important ligaments in relationship to the umbilicus, they are important exam questions. What is the applied aspect of the umbilicus? So one important thing is omphalocele. This occurs due to failure of reduction of physiological herniation of midgut loop. Herniated loops of small intestine are covered by the amnion. So normally when the fetus develops, as the midgut develops, the loops are outside the umbilicus, but by the end of 11th week, these loops come back into the abdomen. So, but sometimes this physiological herniation does not resolve and it stays there. So that becomes the omphalocele. Then there is congenital umbilical hernia. Occurs due to herniation of loops of small intestine through imperfectly closed umbilicus. The herniated loop is covered by the peritoneum. So again, the herniated loops will stay there and umbilicus is not properly closed. So here all the layers will be there, including the skin. So it will be hernia. Fecal fistula occurs due to patency of vitelo-intestinal duct. So ileum will communicate with the exterior. So there will be continuous passage of fecal contents from the umbilicus. Now the urachus, which is joining the umbilical urinary bladder to umbilicus, if that remains patent, then there will be dribbling of urine from the umbilicus, and that is known as urinary fistula. So that is dribbling umbilicus. Then caput medusae, as I told you, umbilicus is the site of portocaval anastomosis. So if there is portal hypertension, the blood flow increases and the veins will become marked. So that becomes the caput medusae. Then there will be referred pain in the appendicitis, because T10 segment is supplying the umbilicus and it is also supplying the appendix. So if there is irritation in the appendix, the same pain will be referred to umbilicus. So these are the important aspects of applied aspects of umbilicus, why this structure is important. Now the transpyloric level indicates pylorus of stomach, duodenojejunal flexure, fundus of gallbladder, renal hyla, and neck of pancreas, all of the above. Which is the correct answer? Yes, correct. All of the above is the correct answer, because this plane when passes, it cuts all of these. Bifurcation of abdominal aorta presents at the level of plane of iliac crest, which is at level of, what is the level? L4. Perfect.
L4.
Perfect. Which of the following is false related to acute appendicitis in pregnancy? Signs can be relatively subtle. progression of pathology can be rapid due to failure of omentum to assess problem and seal it off. There is upward displacement of cecum and surgical incision of appendicectomy it as McBurney's point, or none of the above, which is false. Which is false statement.
B
is the false statement, right? Absolutely correct. D is false because we don't use this McBurney's point in pregnancy. In pregnancy, there is upward displacement. So you will look for the point of maximum tenderness. Very good. So very well understood. This is pyramidalis is supplied by which nerve? This is a very important question. Very vestigial muscle, but favorite of RCOG. So which nerve supplies pyramidalis? You remember I talked of pyramidalis? Small vestigial muscle on the lower end of rectus abdominis. So which nerve supplies? Subcostal. Very nice, very nice. Good. So this is the subcostal. While making the longitudinal incision for classical cesarean section, pyramidalis is used to determine midline and location of the linea alba. Origin is pubic symphysis and pubic crest. Linea alba is the insertion, and subcostal nerve is the nerve supply. So that's how we do, and that's how it's done. That's how you can conquer. So those who want to continue with us for the course further, so these are the numbers which you can contact. You can take the screenshot, or you can find our poster in your group also. So those who want to continue, they can stay with us. We'll be happy, and we are happy to share that since the inception for last 3.5 years, all our batches have maintained consistently 100% pass rate. Because we cover all subjects, all you have seen, we do interactive sessions, recordings will be there, subject-wise tests will be there, question practice, lot of question practice, and it really helps. Around 1500 questions question bank we provide you when we provide you with various mocks and tests. Finally, mock test is there. So we welcome you. Those who have joined, they are welcome. And those who are still thinking, they can start doing, because the success is assured. So you can use, if you want to celebrate your success with us, you are welcome. Right, so this finishes today's lecture, and I'll post this recording in groups, our MRCOG part 1 help part, MRCOG help part 1 group also, so that you can listen to it. Any questions from anyone? Any type of question regarding MRCOG, regarding paper, or regarding the content I have taught? You are welcome. Welcome, dear. Welcome, dear. Any questions? Any questions from anyone?